Electrocardiogram Correlation with Cardiac Events by Christy Wilhelm. An electrocardiogram, also known as an ECG or an EKG, is a non-invasive diagnostic tool used to measure and record the electrical activity of the heart over a period of time. It provides a graphical representation of the heart's rhythm, rate, and electrical conduction patterns by detecting electrical impulses generated during each heartbeat. The primary purpose of an ECG is to identify abnormalities in heart function such as arrhythmias, myocardial infarctions, which is a heart attack, and conduction blocks. By analyzing the characteristic waves and intervals such as the P wave, the QRS complex, and the T wave, clinicians can assess the structural and functional integrity of the heart. The heart functions through an intricate electrical system that controls the timing and sequence of muscle contractions. Though the sinoatrial node, or the SA node, located in the right atrium, initiates the electrical impulse that travels through the atria, causing the P wave, down the atrioventricular node, or the AV node, then along the bundle of the His and the Purkinje fibers, to stimulate ventricular contraction, represented by the QRS complex. The T wave reflects the repolarization of the recovery phase of the ventricles. ECGs are vital in clinical settings because they offer immediate insights into acute and chronic cardiac conditions, guiding emergency interventions, monitoring therapeutic effects, and they help predict patient outcomes in conditions like coronary artery disease, electrolyte imbalances, and heart failure. The ECG waveform is composed of several key components, each representing a specific phase in the heart's electrical cycle. The P wave reflects the atrial depolarization, which is the electrical activation of the atria as they prepare to contract and push blood into the ventricles. Following the P wave, the PR interval represents the time it takes for the electrical signal to travel from the sinoatrial node through the atrioventricle node and into the ventricles. A normal PR interval indicates that the electrical conduction between the atria and the ventricles is functioning properly. The QRS complex represents ventricular depolarization, the rapid spread of electrical impulses through the ventricles, triggering their contraction and the pumping of blood to the lungs and body. This complex is typically the most prominent part of the ECG and occurs quickly due to the large muscle mass of the ventricles. After the ventricles contract, the T wave appears, indicating ventricular repolarization, or the recovery phase when the ventricles prepare for the next contraction. The ST segment, which lies between the QRS complex and the T wave, reflects the period when the ventricles are uniformly depolarized. Abnormalities in the ST segment, such as elevation or depression, are key indicators of conditions like myocardial ischemia or an infarction. An ECG is an essential tool in detecting myocardial infarctions, or MIs, commonly known as a heart attack. One of the hallmark signs of an acute MI is an ST segment elevation, which indicates a complete blockage in a coronary artery and is classified as an ST elevation myocardial infarction, or a STEMI. Conversely, the ST segment depression or T-wave inversion may signify non-ST elevation myocardial infarction, which would be an NSTMI, or myocardial ischemia, where there is partial blockage or reduced blood flow without complete atrial occlusion. These patterns help clinicians quickly diagnose and determine the severity and timing of the cardiac event, which is critical for initiating appropriate treatment. ECGs are also crucial for identifying cardiac arrhythmias or abnormal heart rhythms. Atrial fibrillation, or AFib, is a common arrhythmia characterized by an irregular rhythm and the absence of a distinct P wave, resulting from chaotic electrical activity in the atria. This condition increases the risk of stroke and heart failure if left untreated. Ventricular tachycardia, or VTAC, on the other hand, is a potentially life-threatening rhythm originating in the ventricles, recognized by a fast heart rate and a wide QRS complex in the ECG. Early recognition of these arrhythmias through ECG monitoring allows for timely intervention such as medication, electrical cardioversion, or defibrillation, depending on the severity and the underlying cause. The ECG always plays a crucial role in diagnosing the type and severity of the MI. A key ECG finding in acute MI is the ST segment elevation, which indicates a complete and prolonged blockage of a coronary artery, leading to full thickness damage of the heart muscles. This condition is known as ST elevation myocardial infarction and typically requires immediate reperfusion therapy, such as percutaneous coronary intervention or thrombolytic drugs. In contrast, the XT segment depression or P-wave inversion could suggest a non-ST elevation myocardial infarction or a myocardial ischemia, where the damage is usually less extensive but still clinically significant. These patterns reflect partial blockage or reduced blood flow, and they also guide clinicians in choosing an appropriate treatment strategy. The evolution of ECG changes over time, following the myocardial infarction, provides valuable information about the stage and progression of the cardiac event. In the early phase, minutes to hours, a patient with ST-EMI may show tall peak T waves that evolve into the ST segment elevation. Over the next several hours, the ST elevation may persist, followed by the development of a pathologic P wave, indicating irreversible myocardial damage. Within days to weeks, the ST segment usually returns to baseline, but the T wave remains inverted for some time. The Q waves remain as a permanent marker of a previous MI. Monitoring these sequential changes allows healthcare providers to assess infarction size, timing, and response to treatment. ECGs are instrumental in diagnosing cardiac arrhythmias, which are irregularities in the heart's rhythm or rate. One of the most common arrhythmias is the atrial fibrillation, which appears on an ECG as an irregular rhythm without identifiable P waves. Instead of organized atrial contractions, AFib shows the erratic electrical activity in the atria, leading to an inconsistent ventricular response. This condition increases the risk of blood clots, stroke, and heart failure if not managed properly. Recognition of AFib on ECG enables timely initiation of anticoagulation therapy and rhythm or rate control strategies. Another serious arrhythmia identifiable on an ECG is ventricular tachycardia, which represents a fast heart rate with a wide QRS complex. This rhythm originates in the ventricles and can quickly deteriorate into ventricular fibrillation, a life-threatening condition requiring immediate intervention. The ECG also helps differentiate between bradycardia, defined as the heart rate below 60 beats per minute, and tachycardia, which exceeds 100 beats per minute. Bradycardia may represent long intervals between beats, while tachycardia displays rapid, often irregular intervals. Identifying these patterns is crucial for guiding treatment, whether it involves medication, pacemaker implantation, or emergency resuscitation. A 60-year-old man presented to the emergency room department with a sudden onset of severe chest pain radiating to his left arm, accompanied by shortness of breath and diaphoresis. Upon initial elevation, vital signs showed elevated blood pressure and a rapid heart rate. An immediate 12-lead electrocardiogram was performed, revealing significant ST segment elevation in the anterior leads, consistent with an acute anterior wall ST elevation myocardial infarction. The presence of the ST elevation confirmed the suspicion of a full-thickness myocardial infarction due to complete occlusion of the coronary artery. The ECG findings prompted rapid activation of the cardiac catheterization team, and the patient was taken directly to the cath lab for emergent coronary angiography and percutaneous coronary intervention. 100% blockage was identified in the left anterior descending artery, and a stent was successfully placed to restore the blood flow. The ECG not only enabled a swift diagnosis, but also guided the urgency of treatment, reducing the time to reperfusion, which is critical in preserving heart muscle and improving survival. Post-procedure ECG showed resolving ST elevations, indicating the reperfusion's success, and the patient was admitted for monitoring and further cardiac care. While ECGs are invaluable tools in diagnosing a wide range of cardiac conditions, they also have important limitations. One of the major drawbacks is that an ECG provides only a snapshot in time and can miss intermittent or transient cardiac events, such as paroxysmal arrhythmias or brief episodes of ischemia that are not present during the recording. For patients who report symptoms like occasional palpitations or chest pain that do not occur during the ECG, continuous or extended monitoring with Holter monitors or even event recorders may be necessary for an accurate diagnosis. Additionally, the ECG interpretation must always be correlated with the patient's symptoms, clinical history, and physical examination to avoid misdiagnosis. For instance, nonspecific ST waves change may not necessarily indicate myocardial infarction and could be related to electrolyte imbalances, medication effects, or structural heart changes. Because of these limitations, ECGs are often supplemented by additional diagnostic tools such as an echocardiography, which provides real-time imaging of the heart structure and function, and blood tests for cardiac biomarkers like troponin, which can detect myocardial injury. Together, these tools help provide a more comprehensive and accurate assessment of the patient's cardiac status. So to summarize, the ECG serves as a frontline diagnostic tool in both emergency and routine clinical settings due to its ability to quickly assess the heart's electrical activity. It provides immediate insight into the heart rate, rhythm, and conduction patterns, making it essential for the detection of conditions such as myocardial infarction, arrhythmias, and ischemia. As a non-invasive, low-cost, and widely available test, the ECG is often the first step in evaluating patients with chest pain, palpitations, syncope, or cardiovascular symptoms. Recognizing key ECG patterns such as ST segment elevation, ST depression or T-wave inversion in ischemia or NSCMI, and irregular rhythms with the absent T waves in atrial fibrillation can guide prompt and appropriate treatment. Its role in the early detection and management of cardiac events cannot be overstated, as timely interpretation of ECG results can lead to life-saving interventions like catheterization, medication, or defibrillation. While ECGs have limitations when used in conjunction with clinical evaluation and other diagnostic tools, they remain a cornerstone in the modern cardiovascular care. Thank you for taking the time to listen. For further information, please check out these two references I used. Thank you.